Good morning, everyone. Welcome to this week's webinar session. Just to confirm one more time, can everyone hear us?
Yes.
All right. Dr. Makonda?
Yes, morning. Morning.
Hi, Dr. Makonda, can you hear us?
Yes, I can hear you. Can you hear me? Yes.
All right, so we are touching on pediatric topics today. We have two speakers. So we would like to start with Dr. Ningi Makondo. We'll be discussing VUR and management. I don't know if Dr. Makondo, you can hear us. If you can just indicate if you can hear us.
I can hear you. I can hear you. I can hear you.
Yeah. All right. Thank you so much. Do you mind sharing your first slide so we can start with your presentation? Just wait. All right. Thanks so much. I don't know if you can make it. Okay, I think I have to do it from our side. Okay. Yeah. All right. Thanks a lot, Dr. Ningi Makando, registrar from Vets University. We'll be discussing on vesicoureteric reflux. You can start. Thanks a lot.
Morning, everybody. As just said, I am presenting on vesicoureteric reflux this morning. So vesicoureteric reflux or vesicoureteral reflux is the anatomical and or functional disorder where there's retrograde flow of urine from the bladder to the upper tracts. The etiology for primary reflux is said to be a congenital defect in the structure and the function of the vesicoureteric junction. So you have an abnormal vesicoureteric junction anti-reflux mechanism with a normal bladder and ureter. And this is due to the lack of the 5:1 ratio of the tunnel length to the tunnel ureter diameter, which causes a short intramural ureter and or an excessive ureteral diameter. In terms of secondary reflux, it's due to a normal vesicoureteric junction function that is overwhelmed by bladder dysfunction, whether it be congenital, acquired, or behavioral. And this can be caused by a mechanical obstruction, such as posterior urethral valves or prolapsing urethrocells in females, or functional obstructions such as a neurogenic bladder, dysfunctional voiding in older children, and uninhibited bladder contractions. We need to understand the functional anatomy of the anti-reflux mechanism and know that the functional integrity of the ureter, as well as the anatomical composition of the vesicoureteric junction and the functional dynamics of the bladder actually help within the controlling of this mechanism. So with the functional integrity of the ureter is known as a dynamic conduit, which basically propels urine boluses in an antegrade fashion via neuromuscular propagation of peristaltic activity. This antegrade flow keeps the urine from refluxing and reaching the renal pelvis. And in terms of the anatomic composition of the VUJ, we know that the intramural portion of the ureter travels intravesically within the detrusor muscle and creates an anti-refluxing valve. For this valve to actually be functional, you need to have an adequate intramural length and fixation of the ureter between the intravesical and extravesical points, and this helps create the anti-refluxing compression valve. Paquin described or said that it needs to be in a 5:1 ratio of the tunnel length to ureteral diameter for non-refluxive junction. And we know that the extravesical bladder hiatus, or at the extravesical bladder hiatus, we've got the 3 muscle layers which separate into the outer circular smooth muscle layer that normally merges with the outer detrusor muscle to form the wild eye sheath and contributes to the trigone formation. And we get the intramural longitudinal smooth muscle layer, which merges with the muscle intravesically and contributes to the superficial trigone. And the outermost layer is found within the distal ureter and bulks the posterior muscle bulk. With the functional dynamics of the bladder, we can know that the intramural ureter normally gets passively compressed by the bladder wall during filling and prevents the urine from entering the ureter. But the main mechanism that helps with the anti-reflux mechanism is the active and passive flow of the dynamic reconfiguration of the tunnel length and diameter, which allows the antegrade urine flow and prevents retrograde flow. And so on active opening of the VUJ, you've got active contraction of the longitudinal muscles within the tunnel, which draw together the extravesical and intravesical points that are within a 5:1 ratio of the intramural ureter. And this helps with the shortening and widening of the tunnel and allowing the urine bolus passage into the bladder. And with the passive closing of the VUJ, you've got compression of the intramural ureter that then returns to full length of full tunnel length as the ureteral muscles relax. And this all helps with the anti-reflux mechanism. In terms of classification for reflux, we use the International Reflux Society's Committee's classification system that is based on the imaging that we get from the VCUGs, or voiding cystourethrophotographs. And we know that grade 1 is reflux into an undilated ureter only, grade 2 into the renal pelvis and in the calyces still without dilatation. In grade 3, we get mild to moderate dilatation of the ureter and renal pelvis as well as the calyces with minimal blunting of fornices. In 4, moderate ureteral tortuosity and dilatation of the pelvis and calyces. And in 5, we get a gross dilatation of the ureter, pelvis, and calyces with a loss of papillary impression and severe ureteral tortuosity. The epidemiology of reflux, it's a common neurological anomaly in children and said to represent about 1% in terms of incidence. And we know that the incidence decreases as the age of the child increases. In the general pediatric population, it's said to be between 0.4 to 1%. And in infants who have a prenatal hydronephrosis and ultrasound, it's said to occur in about 16.2%. In terms of sex and gender, we know that males will account for 14% of patients with VUR, and they've got an increased incidence of about 30% if they present with concomitant UTI. And we also know that males are diagnosed at a young age and with more severe grades of reflux. Females, on the other hand, tend to be diagnosed at an older age, and this is mainly due to their susceptibility to urinary tract infections due to their urethral anatomy. And in terms of race, it's said that Caucasians have a 10-fold increase in comparison with their African counterparts. However, we know that race is a social construct, and most of the studies that are done where they look at epidemiology are done in the Western context, where African population is actually not in the majority. So we can not really extrapolate much from the race. In terms of inheritance, we know that the offspring of parents with a reflux have an incidence of about 35.7%, and siblings of children with reflux have an incidence of about 27.4%. We do not routinely screen for siblings with reflux anymore because you need to screen a large number to actually prevent a single UTI, so it's not cost effective. And we now know that reflux detected in sibling screening is associated with a lower grade and earlier or better spontaneous resolution in the pediatric population. So why is VUR a problem? And this brings us to Ramsey and Risen's Big Bang effect, which basically says, or in basic construct that says that most anatomical susceptible areas of the kidney that get scarred in early episodes of febrile UTI with VUR is due to the intrarenal reflux, where the scarring tends to occur at the renal poles, where the anatomy of the renal papillae permit the backflow of urine into the collecting ducts. And thereafter, beyond the fetal stage, the anatomic reflux alone will really produce any renal damage or any progressive changes in the patient. And this brings us to the next bit of a problem, which is whether we have to evaluate the pediatric population of the patient, either with a top-down versus a bottom-up approach. Because as previously stated, scarring and repeated infections cause hypertension and reflux to nephropathy to progress to end-stage renal disease that might need dialysis as well as transplantation. So we need to identify patients susceptible to renal damage with the three imaging modalities that have been standardized, which is the renal bladder ultrasound, the voiding cystourethrogram, and DMSA, and then now decide whether we're going to emphasize on whether the appearance of the kidney or the presence of the reflux is the most important place to start in terms of evaluation. So the bottom-up approach, which is the historical or the classical approach, is where the patient presents with a febrile UTI and we rely on the renal bladder ultrasound to identify a renal parenchymal defect or evidence of obstruction. Then you obtain a VCU to target the lower urinary tract abnormalities and to detect the reflux. If the patient's diagnosed with reflux or parenchymal deformity, may then undergo a DMSA scan at a later stage to assess if they've got renal scarring. If it is positive, then they may undergo medical or surgical treatment of the reflux. If they don't have it, then you need to assess for bladder and bowel dysfunction. And with the top-down approach, we start at the kidney. Patient presents again with a febrile UTI. and you have a DMSA scan to diagnose acute renal parenchymal scarring at the time of the febrile UTI. And those with photon defects or evidence of parenchymal inflammation will then need a VCU to assess the grade or severity of the reflux. And you need to repeat the DMSA scan 6 to 12 months later to assess if there is any permanent scarring. In 2021, Wang and colleagues did a comparative effective analysis using the review study, which is the randomized intervention for children with reflux, using Bactrim as antibiotic prophylaxis, and the QT data, which is the careful UTI evaluation, which looked for risk factors for developing renal scarring children secondary to UTI. And they found that the top-down approach is associated with a slightly higher recurrent UTIs and significantly reduced the need for VCUs and continuous antibiotic prophylaxis. So again, with this subgrouping, if they're positive in terms of the DMSA and VCU, they get medical and surgical treatment of reflux. And if they're negative, you have to assess bladder and bowel dysfunction. With the bottom-up VCUG, the advantages of it is that it's widely available, it's reproducible, and you can easily interpret it, and it identifies the lower corrector anomalies. But the disadvantage is that it actually requires this catheterization, which distresses many patients. It does not fully identify all vulnerable kidneys, and you have focused ionizing radiation in a pediatric patient, and you may overtreat certain patients. With the renal ultrasound, it's non-invasive, it's got non-ionizing radiations widely available, but it fails to alter the management in many abnormalities, and it's not a functional study. And the advantages of the top-down DMSA is that you can identify the kidneys which are vulnerable to injury, avoid the VCU, and avoid the VCU catheterization, which normally distresses patients and parents. And it's an acute phase scan, which has high sensitivity and specificity for reflux and recurrent UTIs. However, it's not that heterogeneous in availability and quality and interpretation. And you require intravenous access and long appointment times, and sedation of the young children, misses certain cases of VUR, and exposes the patients to diffuse ionizing radiation. As a side note, bladder and bowel dysfunction, which is mentioned in the EUA guidelines, is dysfunctional or abnormal pattern of urination and defecation, which produces high intravesical pressures during voiding and post-void residual, which worsens reflux. Clinically, patients who have bladder and bowel dysfunction normally complain of constipation and lower urinary tract symptoms, and they're at higher risk of breakthrough urinary tract infections during a continuous antibiotic prophylaxis, as well as low rates of spontaneous resolution while they're on continuous antibiotic prophylaxis. It's important to treat these patients with behavioral therapy such as regular or time voiding intervals, anticholinergics if they need that, and alpha blockers, and biofeedback if the children are older than 5 years of age, and to manage their constipation, especially if you're trying to rule out or trying to manage the secondary causes of reflux in the patient. Okay, so in terms of reflux evaluation and diagnosis, clinically, you've got two arms of presentation: those that are seen prenatally on ultrasound via hydronephrosis or urethral dilatation, or those that can present with a UTI postnatally in life. And the patients at greater risk are the children with febrile UTIs, any male with the urinary tract infections, and urinary tract infections in children less than 5 years of age. And with reflux, we normally start with a detailed history and physical examination. And bedside investigation is important to always do a blood pressure, weight, and height, because we know that cortical renal scarring and propagation of this will cause somatic growth retardation in most of these kids. You get your bedside ultrasound to rule in your hydronephrosis and cortical scarring with increased leukogenicity on ultrasonography. And your urine dipsticks, you look for leukocytes to confirm that you do have a UTI or you could have a UTI, and proteinuria to show that you've got some renal dysfunction. And biochemistry, we're always told to just get a white cell and CRP for infective markers. Is serum creatinine, especially if you're suspecting or thinking of renal dysfunction. And you also want to diagnose your urinary tract infection via urine MCNS, which you either, and make sure that you collect your urine either as a midstream urine, clean catched, or a suprapubic aspiration in the children. In terms of imaging, We again start with the renal and bladder ultrasound, which has always been described as the first-line modality to assess for evidence of scarring and renal growth retardation and renal scarring due to pyelonephritis. We know the voiding cystourethrogram is the gold standard for the detection of grading reflux. And we can also undertake the radionuclide cystography, which basically identifies the bladder and ureter for any abnormalities by using a 99M sodium pertectinate and a gamma camera. Advantages of doing the RNC is that you get less radiation with a greater sensitivity of grade 2 and 5 reflux. However, you are limited in terms of the fact that it's poorly sensitive to grade 1 reflux, and it's more expensive, and it gives less anatomical detail due to the fact that the ureter is obscured by the bladder. And it has a limited grading system, which is in 3 points, where the lower grade corresponds with grade 1 of the International Reflux Study Committee, intermediate with grades 2 and 3, and high grade with grade 4 and 5. We can also use urothermetry to establish the functional status of the bladder, and if the bladder outlet is functional, and to rule out poor flow rate related to incomplete relaxation of the bladder outlet, and urodynamic studies to determine the bladder capacity and uninhibited contractility and compliance of the bladder. The uroflowmetry and urodynamic studies help with ruling out the causes of secondary reflux so that we can actually manage them prior to actually undertaking definitive management for the reflux in the patients. And then with renal scintigraphy, which is done with your dimercaptosuccinic acid, is the gold standard for imaging functioning renal parenchyma, which is 98% sensitive and 92% specific. And basically, you get the radio tracer taken up by the proximal tubular tissue masses, and you get areas of acute inflammation. And in the areas of acute inflammation and scarring, you normally have poor uptake, which will appear as cold spots. And this gives us a proportional representation of glomerular filtration and renal parenchymal function. In terms of a neuromodality, we are starting to look at the sonographic voiding urography, which is basically an ultrasound with contrast. And it helps, and it's said that detection of reflux with this modality is comparable to a voiding cystourethrogram. It avoids ionizing radiation, and you can have multiple cycles, so prolonged imaging under this modality. However, it is operator dependent because it is an ultrasound. There is no standardized grading system determined for this yet, and it is still being debated whether you can determine the bladder and urethral anomalies with this modality in the meantime. So we should watch out for it. So reflux has an extremely variable natural history, and that ranges from spontaneous resolution all the way to end-stage renal disease. And there's a subset of children with persistent reflux who remain at risk for recurrent pyelonephritis, as well as having potential sequelae from renal injury. And you need to delineate which of these patients are most likely to resolve without intervention from these, and those that have a potential to cause irreversible renal damage. And the ability to predict which patients with reflux will resolve has profound implications in management. And thus there have been a number of calculators designed for spontaneous resolution predictions, such as the Tish et al., who introduced the VUR index as a predictive model for VUR improvement and resolution in children younger than 2 years with newly diagnosed reflux. They used the variables of gender, the reflux timing, urethral anomalies, and reflux grade, as well as total reflux, and gave a graded system between 1 and 6, 1 being closer to spontaneous resolution and 6 further away from resolution. And this validated tool that basically predicted the spontaneous resolution of reflux, or at least 2 grades of improvement for patients diagnosed before 2 years of age. And they found that the index is valid for reflux resolution in children older than 2 years of age. So there are numerous factors that contribute to resolution, such as your patient age, your grade, your ureteral orifice and BUJ anatomy, your length of the ureteral submucosal tunnel, and your intravesical detrusor pressure. But we also know that resolution can also happen spontaneously. And if you look at it by grade, the low grades mostly resolve spontaneously. 50% of the cases with unilateral grade 3 are said to resolve spontaneously as well. And less than 25% of the patients with a grade 4, grade 5, or bilateral grade 3 reflux are said to resolve spontaneously. And in terms of age, we know that the younger you present, so in neonates and young children who present earlier in life, especially in less than a year old, have the greatest tendency to resolve spontaneously as well. And those that have persistence in early life will also probably have persistence when they're older. And again, with the long-term sequelae, we know we get hypertension and renal growth impairment, renal failure from focal scarring, generalized scarring and atrophy, renal failure of renal growth, as well as somatic growth from reflux. And this is why we need to actually manage it and appropriately. So in terms of the management approach, we don't have a strict guideline, but the goal from most of the guidelines, whether it be the EUA, AUA, the American Association of Pediatrics, is that you have to actually just preserve renal function and minimize the risk of pyelonephritis. And you do this by individualizing the treatment based on particular preference of the treating physician. You first have to define and analyze the risk factors for each patient by looking at the grade and severity of the reflux, the age of the child, the gender, the presence of any anatomical abnormalities or bladder and bowel dysfunction, renal status, look at the renal cortical abnormalities or scarring, and the family history. Thereafter, we have to get standard imaging, whether it be your renal, whether you do the top-down approach, which is your DMSA and VCU, or if you're doing the bottom-up approach, which is your ultrasound and then VCU. And thereafter, you have to choose a management plan, which can either be medical, surgical, endoscopic. And this is also helped by the ability of the child or caregiver to comply with the treatment, or as well as the preference of the child and caregiver. So it's a multidisciplinary approach. In terms of medical management or watchful waiting, we need to maintain sterility by judicious use of single daily low-dose antimicrobial prophylaxis. They say you should only use a quarter of the intended dose. And we do this via a continuous prophylactic of antibiotics until the resolution of reflux. If the child is less than 2 months of age, you use your amoxicillin and ampicillin, and the child is greater than 2 months of age, then you can use your trimethoprim sulfamethoxazole or your nitrofurantoin. And in 2014, the review study, which investigated the effect of continuous antibiotic prophylaxis using Bactrim on the UTI recurrence in children, said that about 50% of the children on CAP had decreased risk of recurrent UTI. So the continuous antibiotic prophylaxis actually does work, and it is effective in decreasing UTIs in children with reflux. There's no difference in scarring in the Bactrim or placebo group, and we also know that the placebo subset actually started having resistance to Bactrim, but this resistance decreased over a 2-year period. So the duration of CAP is, you're normally told that you have to start it and you have to wait until the child's approximately 5 years of age. And if there's no breakthrough infections, then you can actually withdraw from prophylactic antibiotics. However, if there is any breakthrough UTI, it's an indication to terminate your watchful waiting. During the time while you're continuing your continuous antibiotic prophylaxis, you need to make sure that you do an annual blood pressure, weight, and height, again for somatic growth retardation, an annual urinalysis, and renal bladder ultrasound to review your progressive cortical scarring and degree of hydronephrosis. They recommend a 1 to 2 year VCU, and it's said that if you get a single cystogram without refluxes, it's sufficient enough to rule in resolution of reflux or spontaneous resolution. And the DMSA is only normally recommended if you've got elevated serum creatinine with renal cortex scarring and ultrasound, or if there's high risk of renal scarring within the patient that is being reviewed. So for the surgical management or open surgical management, the indications for anti-reflux surgery are because of a breakthrough UTI despite adequate antibiotic prophylaxis, if you're non-compliant with medical management, if you've got new renal scars from recurrent infections, if you've got a high-grade reflux with evidence of scarring, worsening renal dysfunction or progression to renal failure, if you've got associated congenital anomalies of the VUJ, or if you've got persistent reflux with females in puberty or those prior to pregnancy. And with the surgical management, we know that the reimplantation has a 96% success rate as proved by Peters and colleagues in 1997, with grade 1 being 99% successful and all the way up down to grade 5 at 80.7% success rate. So there are lots of approaches, but we're going to start off with the intravesical approaches. And the first technique we go into is the polytonal-lead-batter, which uses a new hiatus, which is suprahiatal, and goes through the same ureteral orifice. And the advantage of this is that you get a long tunnel with a good, which is great for high-grade VUR or reflux. But the disadvantage is that sometimes you can get kinking and hooking of the ureter, which actually can cause obstruction in the patient. The Glenn Anderson uses the same hiatus, but it then goes infrahiatally. You get a new ureteric orifice, which is inferior to the native ureteric orifice. And this helps avoid the kinking of the ureter. However, it causes limitation in the tunnel length. And you also can get distal, and your distal anastomosis is also quite difficult with this technique. The technique that is the most preferred is the Cohan cross-trigonal, which uses the same or the infrahiatal hiatus. And an infrahiatal approach, and you get a new superior and contralateral ureteric orifice in relation to the native ureteric orifice. You get a long tunnel without distal anastomosis difficulty. It's great for small bladder and thick bladder walls. It really kinks or obstructs, and it's good for concomitant bladder neck reconstruction. Only problems with it is once you have crossed the ureter to the opposite or the contralateral side, it will become difficult to visualize and recannulate the superlateral UO in future studies. In terms of the extravesical approaches, we get the leash-gore technique, and it gives us a stable submucosal tunnel with good length, and you've got low incidence for contralateral reflux, but it is known to cause transient urinary retention in about 20% of the patients, and they postulate that is due to the disruption of nerve to the bladder bilaterally when you retract the bladder during the extravesical approach. And the risk factors for retention post-repair are said to be bilateral reimplantation, young boys under the age of 3, if you've had previous voiding dysfunction and a high grade of reflux. And lastly, we get to our combined approach, also known as Paquin's technique, where you have a new extravesical ureter hiatus is created, and the polytunnel-Leadbetter intravesical approach is then used as the second part. It gives us a stable, long submucosal tunnel, and it's ideal for dilated ureters and for complex reimplants, especially if the initial reimplant has failed. So the early complications from these surgical repairs is that you can get persistent reflux, which is normally associated with a high-grade reflux prior to repair. You can also get contralateral reflux, which is commoner with patients who've had corrections in the duplex systems. You can also get obstruction of the ureters, mainly due to twisting or kinking, if you do the polytunnel-Leadbetter, intramural clots and extramural compression by submucosal hematomas, as well as edema at the anastomotic sites. You can also get urinary retention, as well as bleeding and infection. Late complications are that you can get a suprahiatal obstruction due to kinked or ischemic ureters. You can get a hiatal obstruction due to, which causes a high reimplant phenomena with a full bladder due to the ureter being too lateral and too anterior. You can get a tunnel obstruction, which causes, because you might have difficulty tunneling with neurogenic or a posterior urethral valve bladder because they've got thickened detrusor muscles and difficult to tunnel. And you can also get your ureteric orifice obstruction from ischemic stenosis from surgical techniques. Recurrent and persistent reflux can also occur because of inadequate length to tunnel diameter ratio, poor muscle bulking, especially in the posterior aspect, and secondary reflux that was not addressed prior to the repair. So for follow-up in these patients have been repaired, they always say that you should continue with your continuous antibiotic prophylaxis and repeat your ultrasound at 3, 12, and 24 months. You don't have to do a VCU because of the great success rate of the reimplantation. And but if they have failed and they still have persistent reflux at 24 months and greater, then you should consider doing a redo implantation. And we normally use the Paquin technique or the combined technique at this point, where you excise all ischemic segments and you need to create a new hiatus and a new submucosal tunnel. And if you've got issues with length, you can always employ the Sowers hitch for these patients. And then we get to the endoscopic management, where we started looking at the subureteric Teflon injection, also known as STING, which is where you inject a bulking agent submucosally into the subureteric space. It was then modified by the Dublin modification, and they then said that you should rather insert the needle into the submucosal plane, but within the intramural ureter. So basically what happens here is you've got a needle that you inject with a bevel facing up in a 6 o'clock direction. And you either go into the subureteric space or then to the submucosal portion plane, and you inject a little bleb. And if you are in the right plane and you're sure you're in place, then you inject the full bleb until you get a little volcano. And this volcano is said of your bulking agent is said to compress the ureteral lumen and substitute the normal muscle backing. And it improves the coaptation of the intramural ureter. And it's fantastic because it's minimally invasive and you can do this as an outpatient procedure for most patients. So the material used for this endoscopic correction should ideally be non-toxic and stable without migrating to other organs. They should cause minimal local inflammation. They should become well encapsulated, and they should be easy to inject and viscous enough to prevent leakage from the puncture site. And they should be durable to maintain an injected volume and shape of the normal tissue and interactions. So we use the non-autologous materials like your PTFE with paste, which was the first one that was actually used. But this has been known to cause distant migration and local inflammation, and you need a rat syringe to actually inject it. The cross-linked bovine collagen, also not as durable and also causes allergies in 3% of the patients. And we've got the polydimethyl siloxane, or PDS, which is known to migrate and also needs a rat syringe. And the one that is mostly in favor is your dextroamer hyaluronic copolymer, also known as D-Flux. It's not as durable, but it is still the most preferred, and your coapatite, which is not durable, which is easily injectable, but you're not using it as much. Your autologous materials that you can use are your chondrocytes, your fats, and your collagen, your muscle. Problems with these is that you actually have to harvest them, and they're not as durable as you would have thought they would be. So Roth et al. In 2010 did a systematic meta-analysis evaluating the dextroamer hyaluronic acid for reflux and estimated that the success rate was the average success rate was at 72%, with 89% success at the grade 1s and all the way to 62% at the grade 5 reflux. And post-op follow-up, post the endoscopic correction, is that you have to continue antibiotic cover for 3 months. At the 3-month point, you have to follow up with an ultrasound and a VCQ. If you still have reflux, then you can repeat the injection at 6 months after the initial injection. And if you still have persistent reflux after the second time you have injected, then they recommend you do open surgery. And we know that we can get recurrence of reflux post the endoscopic correction. If you use the Teflon paste, there's said to be a 5% recurrence in the 17-year follow-up. And in the Swedish reflux trial, found that 20% of previously successfully treated children had recurrence after 2 years of follow-ups with the D-Flux, even though it's still the preferred material, but it's not as durable. With the extravesical, and then we get to a laparoscopic correction. We get 3 different types here. We've got the extravesical replantation, which is the most common, but technically difficult. And it's very challenging because you have to expose the ureter and you can cause trauma to the ureter, and you have to develop an extravesical tunnel, and you normally injure the urothelium and the long operative times, as well as the steep learning curve. And you can also get the Gilvonek procedure, which is where the trigonal mucosa is inside vertically and the ureters are approximated into the midline with a single submucosal suture. The least successful at success rates of 62.5% and not really used. And then the one everyone prefers is the Cohen cross-trigonal reimplant, which uses the standard laparoscopic instruments, and you can either go transvesically or transperitoneally, causing a pneumovesicum with carbon dioxide. Then we also look at your robotic assisted laparoscopic extravesical ureteral reimplantation, or the RAILU, which is the latest mode, where we've got your submucosal tunneling and your ureteral anastomosis. And the advantages of using the robotic assisted extravesical reimplants is that you avoid transgressing the peritoneum. You circumvent with any challenges associated with the small pelvis that you find in children. It's not cost effective, and of course, it's got a super steep learning curve. In summary, we don't have strict guidelines on how to manage, but we know we have to maintain and preserve your renal function and minimize the risk of pyelonephritis. You have to identify the patients at greatest risk, which are your children with febrile UTI, the males with UTI, or UTI in children less than 5, according to the risk factors that they present with. And you have to take steps to prevent recurring febrile UTIs and prevent renal injury and minimizing the morbidity of treatment and follow-up. And of course, most importantly, you have to manage the underlying cause in secondary reflux prior to you actually managing the patients. Thank you very much.
Hi, Ningi, Dr. Makonda. Thank you so much for an excellent overview on VUR. I don't know if there's any questions for you from anyone. You mentioned that the top-bottom approach is associated with increased risk of recurrent UTIs. Do you mind explaining how one would get that?
Sorry about that. There's a very bad reverberation. Oh, I stopped now. Okay. With the top-bottom approach, as previously stated, you start off with your DMSA, which is your renal scintigraphy, and this normally will point out if you've got cortical scarring. And when you have this, then you go straight into your VCU, which will then show you that you've got reflux. Once you've seen the reflux in these children, you just start monitoring them and you start giving them either your continuous antibiotic prophylaxis or you go into your treatment modalities with the surgical or not. And most of the times you start grading these children into either low grade and then you start monitoring over time. And thus it makes it easier for you to sometimes miss those that could probably stay, that could probably persist longer. And thus you might have more chances of scarring in these patients later on in life as well. I think if I understood it correctly.
Thanks, Dr. Makonda. I'm just going to quickly engage Prof. Lazarus here because it does pediatrics and it deals with all these experts in pediatric urology. Prof. Lazarus, sorry, you're here, so when I use that opportunity, if you can just make a comment in your approach on continuous antibiotic prophylaxis in patients with VUR, which patients you put on prophylaxis and how long, because I think Dr. Makonda was suggesting that up to 5 years you don't get breakthrough. Just want to hear what your thoughts are on your approach.
Thank you, Sam. Congratulations to Dr. Makonda. Very competent talk, nicely put together. Thank you. One thing you didn't tell us was that the Cohen cross-trigonal reimplant was in fact invented at the University of Witwatersrand. A urologist called Joseph Cohen invented it, and he's probably the most used open or laparoscopic procedure these days. But the River trial was thought to be compelling to show that continuous antibiotic prophylaxis helped children with reflux. But I think you need to consider the scenario here, which is that you're going to put these children on prophylaxis for some time. The end point is never clear, because how long do you need to keep them on? We know that the natural history is 2 years. They're meant to be on antibiotic every night, the poor child, for 2 years. So I've never really thought that was a good option, particularly for mothers who look very odd at you if you suggest any medication these days. So that's been the problem with it. But actually, there's a bigger problem with the data, which is that, yes, it reduces UTIs. So you think, well, you've achieved what you're intending to achieve. But it doesn't change the outcome with scarring, which is actually the only metric that really matters here. And it also promotes antibiotic resistance, because you long-term giving a particular antibiotic, and when they do get infected again, it's usually with a more resistant antibiotic. So I've not been compelled by antibiotic prophylaxis. Neither am I compelled in this day and age that we need to do open or laparoscopic surgery for these children, because I think the average community urologist is happy to manage an endoscopic management of reflux. It is safe and it is effective. You didn't mention the Swedish reflux study, which I think provides quite compelling data that it's better than antibiotic prophylaxis in curing and better at reducing scars. So that would be another one to look at. I see there's a message from Karl Heinz. Maybe he'd like to talk.
Thanks, Prof, for that insight. I see there's a...
Morning, Sam. Can you hear me?
Hi, sorry. Sorry, Dr. Yella. I think we seem to be having an unstable network from our side, but sorry for that. Do you mind just addressing your question again, Dr. Yella?
Hi, morning, Sam. Can you hear me now? Hello?
I can hear you, Caroline. I think maybe there might be something with their Wi-Fi.
Yeah, maybe Sam can just read it, and no need for me to talk. Good morning, Shingi.
Morning, bro.
Okay. Okay. Yeah.
Hi, everybody. Just apologies. We're struggling a little bit with the network. We should be up and running shortly. I hope you can hear me okay. Carline's asked a question whether the management of VR and duplex system where you've got a functioning low moiety reflux. So yes, so due to the Paquin, due to the Vagot-Mayer rule, you've got lateral ectopia of the lower moiety. And so lateral ectopia is what the problem is in primary reflux. So that's why you have associated vesicoureteric reflux 50% ipsilaterally and 25% contralaterally. So yes, I think a deflux would be a good option in that scenario where you've got a functional lower pole with associated reflux. I think we're probably going to try and go on to the next talk, but thank you, Dr. Makondo, for your talk.